gang, it's October. It is Breast Cancer Awareness Month. It's after work time. But you know what else it is? It's Hump Day. That means it's happy hour for the dinks. So welcome to Dentists in the Know. This is your backstage look at current trends, politics, and education in the dental world. It's live and it's over a cocktail. That's kind of why I do this gig. I'm Dr. Jeff Horowitz, and these are my co-hosts, Dr. Chad Duplantis and Dr. Jennifer Bell. We are all practicing dentists. We're all educators. We're all business owners. And you know what our job is? It's to bring all of you in the know. So how is it going, my dear, dear friends?
JB, how's it going?
It's going great. I'm coming off of a great weekend. Now, I had two really great weekends because I saw my besties come in. I got to spend a weekend with Jeff and then a weekend with Chad. But this past weekend, my husband and I and our three kids, we went to Kentucky because the horse races at Keeneland are going on. So we spent time with some really good friends of ours. We did some, gambling on the horse races and had a really good time there. Got to spend some time with their friends in Lexington. So it was a great weekend to reconnect and actually had some really good family time as well. So now just back to the grind and kind of hustling through the week. How about you guys?
Crazy week as usual. I didn't really get to elaborate on this last week because we ran out of time, but I'll try and make it quick. So last week had a person who is near and dear to our family who is unfortunately in an abusive relationship. Mm-hmm. Couple of interesting moments in her life, and the last most interesting moment took her two front teeth 3 weeks after one of her front teeth was taken and repaired. So it was a rough week, but on Monday she was able to come in. We were able to get her smiling again. It was a long day, but it was very, very rewarding to be able to know that you were able to help somebody, and not patting my own back, but just based upon some of the conversations that we had amongst our group. We had a very long conversation about maybe her future with this person that's been a little bit of
nice
abusive to her. So
how'd she take that?
She took it very, very well. It went from kind of just how would you say, enabling at the beginning to understanding at the end. I think time is going to tell, because unfortunately it's habitual. But I was able to have, I contacted a law enforcement officer and got some resources for her, found out what her options were and what type of orders need to be put in place to keep that person away from her. And I think maybe it's going to be heading in the right direction. So it was rewarding.
That's so encouraging, because that's half the battle in those situations. Mm-hmm. Is I think the victim often feels helpless, and they almost at times will defend the person who committed the offenses, and what do you do with that? So sometimes if you can just listen and just be someone who can offer some advice in a non-intimidating way. And if you made some impact there, Chad, that's huge. That's gigantic.
I hope I did. But the thing is, as I mentioned in the post last week, that, with a child, we have an obligation. With an adult, it's not necessarily an obligation, yeah. But I feel that it's an opportunity for us to be able to help them maybe find the right path and offer some encouragement. And that's all that we can really do, because it's all accusatory. I mean, it's all accusatory, whether it's a child or whether it's an adult, right. It's accusatory. But as a child, you have an obligation to accuse somebody almost. As an adult, you have an obligation just to counsel, is what I feel. And I certainly wasn't going to turn a blind eye.
I love that, Chad, because, one of the things that I always try to talk about is like, well, we can't be physicians. We can't pretend that we're physicians. We can't be psychiatrists. We can't be anything else. But above all else, I think, aside from being dentists, that we can be advocates, regardless of what the topic is. And as long as we put that disclaimer out, look, I'm not a psychiatrist. I'm not a policeman. I'm not a physician. I think, you know, being an advocate for our patients is what really builds practices. And so, I mean, I always knew that you would be that guy, but you know, I don't want to sound condescending, but I'm proud that you did that. And, you know, good for her and good for you. I mean, it's got to feel good.
Well, my cycling team always called me the team nurse. So, because I would always stop and render aid when needed.
Didn't you once make a porn under that name? Cycling nurse.
Yeah, that's interesting.
Is that a thing?
Topic for next week.
I don't know. I just sometimes I just say what comes into my head before I really think it out.
That was just a bit of a peek in, just a bit.
Yeah. It's a possibility to the future. How was your week, Jeff?
You know, it's been a really interesting week, if nothing else. Looking at some possible business moves forward, and you know, stepping on to that next stage of my career. I'll kind of leave it at that, but I'm really, I don't know, this last year with my folks and kind of coming to grips with aging parents and I guess mortality in general, if we don't want to get too heavy, maybe realize the things that are important to me, like this, and the things that I love doing in dentistry. And so I started looking at possibly releasing some of the responsibilities that I've had for so many years and lightening my burden a little bit. And some of that is kind of coming to fruition now. And it's amazing. It's like, do you ever clean out a closet and just that cathartic feeling of throwing a lot of shit away?
Yeah, that's like, a good feeling. That's a really good feeling.
Yeah, that's kind of where I am. So I don't think it can be more positive than that, than kind of feel like some of the burdens of life are being lifted off of you without, again, I don't want to get too heavy, but it's a nice place to be. So it's been a good week. Is a full moon, and none of the crazy people have really shown up in my office yet.
Not yet.
Yeah, not yet.
They're calling
it is a full moon.
I know. As I said, and none of them have showed up yet. And usually they do. Like, usually the patients show up, then I realize it's a full moon.
Mm-hmm.
And just the fact that I realized it's a full moon this time and the patients haven't shown up yet is a really great sign.
Or Mercury is in retrograde. I had
I don't know all that stuff.
But I had people swear by it. That cathartic feeling that you get from cleaning out a closet. I love that feeling so much that my kids now bring stuff home from school and they'll look at me and go, I really like this one. Can you not throw it away? Because as soon I'm like, that looks great. Ka-chunk. That's great. Ka-chunk.
Yeah.
And so maybe I like that a bit too much.
Yeah, maybe, because I'm a total pack rat. Like, I'm the guy, I still have, I still have love notes from high school. Like, literally, I have a suitcase upstairs that my son will come home at breaks. He will go upstairs and bring like a bottle of wine with his girlfriend and go through my high school shit. Just like, Dad, why did you keep this? Because I could.
Hey, you know what, Jeff? You've got opportunity if Jenny ever leaves you.
That's right.
You have a backup plan.
That suitcase Rolodex you've got in the garage.
Yeah. Hey, JB, notice how I worded that? If Jenny ever leaves you.
Yeah.
Yeah.
Well,
That's the only logical explanation.
yeah. I don't know. Yeah,
If she
I'm
were
not
going to
doing
do it,
any
it would
better,
be
guys. I'm just telling you that
what?
right here. I'm just coming out and saying I'm not doing any better at this point. So
No, I know. I'm worried.
I've
if
kind
she
of thrown
leaves
in the
you-
towel. Yeah.
Yeah, I'm
Everyone
worried.
has
if
met
you-
Jenny's guy, dude. Yeah, don't go.
If she leaves you, you're going to live with one of us, and that's not
Yeah.
going to work either. So.
Exactly.
Because your
So-
dad
Oh,
and
man.
mom can't come too.
Oh, great. Well, we have a really cool show tonight. I think it's something we're going to be talking about something tonight that I think is long overdue for us. There's so much talk about biomimetic dentistry, and I think not just amongst dentists, but amongst our patients now who, you know, I have patients now that come in and like, oh, does that have BPA? I'm like, really? I just learned what BPA was a couple of years ago. How am I supposed to know if there's BPA in that? But, you know, our patients are coming in. They're more informed now. They're better educated. As much crap as there is on the internet, there's also some really good information for people who are smart enough to figure it out. That was an ugly look, JV. There is some good information on the internet.
There is some.
There is some, not all, some. But for people who are really willing to kind of go through it and decipher all this stuff, it's educating our patients, and they're coming to us with really good questions. And so tonight we have a biomimetic dentist who also happens to be a past intelligence analyst from the United States Marine Corps, which I think is pretty cool. I don't know about you guys, but I want to hear more about this. So we have a guest tonight, Dr. Brandon Walker, who is a biomimetic dentist and just going to share a world of knowledge about that part of dentistry that I think we tend to overlook a lot. But before we do that, JV, are you going to fill us in on some of the current topics and news?
Of course, guys, I have a lot written down, but we'll just get through a few things and see what tickles your fancy, what you want to dive into, right? Because sometimes I'll say stuff and it's not very interesting, and then other times we get really knee deep in it. So we're coming off of the ADA conference, which has been kind of going on for the last, it feels like 7 or 8 days now. I don't know, how long is that thing?
It did seem like it was long, but it wasn't.
It does. So SmileCon, and of course, lots of things happen there. There's different convocation ceremonies and things that are happening, but then, yeah.
No, I thought SmileCon was brilliant marketing.
Yeah, I think so too.
Changing like the ADA annual meeting to SmileCon.
I think that was well played.
Yeah.
So new officers were elected. There's a lot of buzz around Shepley coming in to the board as a VP. And then also, is it Sabates, who I believe is a Cuban immigrant who's a dentist or endodontist. Hold on, I'm totally botching this. But he is out of Florida, and he was elected. He's president-elect. So some interesting stuff that happened there, some resolutions. I haven't gotten a full report yet on how the resolutions panned out. I know there was a sleep resolution out there on HSTs. And so as soon as we get updated information on that particular one, just because I was interested in it, but I'm sure there's others that had some impact as well. So as soon as we get that data and information, we'll definitely report out to you guys on that. As I posted today on our Instagram story, the president of the AGD had an opportunity to, I guess, testify, if that's the right word. Testify to me always seems like a negative term, like you're testifying in a court hearing or something that maybe you've done wrong, or you're participating in someone who else maybe did something wrong. But he testified on oral health literacy today in front of Congress. They're looking at a bill that would put some HRSA funding towards oral health literacy. And that's something that both the AGD and the ADA have been really active in pushing through. It's a bipartisan bill that was put forward this year. There is some momentum and we're seeing some activity. So it was nice to see, some of our elected officials having an opportunity to testify, in particular for us GPs to have a platform to speak about oral health literacy and its impact on public health as a general rule. So there was a lot that came out of that. I haven't seen the transcript yet. Hopefully we'll get access to that so we can post it. Guys, there is one thing that's sort of interest. I don't think it will impact the majority of the folks who watch the show, but OSHA did submit their final paperwork for their emergency temporary standard for COVID-19. We talked about this about 6 months ago. They started
right on time.
I know, right? I mean,
sorry.
The Southeast is going.
So I'm going to give you a sorry on that one.
Well, I mean, Florida's sitting there going, we don't even have COVID anymore. I mean, their numbers are so low now that anyway, I was looking at a heat map today of COVID, and the Southeast in general is getting pretty low. But
the new guidelines on dengue fever are out.
We're going to do an ETS on Ebola next, just for fun. Anyway, so they submitted all their paperwork. This is the final step for it to be approved. I don't know what's going to come out of that, except that there is great confidence that they will fall in line with the vaccine mandate of if you have 100 or more employees, it's either mandated vaccines or weekly testing. That seems to be pretty consistent with what we're seeing. There may be other little juicy tidbits in there. We don't know yet. But I expect that will be public pretty soon. So we'll update you as soon as we know. If you work for hospitals or other facilities that don't already fall under some other mandate, then maybe this could impact you. But I feel like most of those places have already sort of fallen under other mandates and things that were coming out. Just a quick vaccine update. Moderna is now approved for boosters.
Any notes on the Black Plague?
No, I don't know anything. Moderna got approved for the booster shot. They now approve vaccines for 5 and up. And they did come out and say Johnson & Johnson should have been 2 shots. So here we go. It just keeps kind of slow. But there's lots of other news out there about, other countries actually pulling away from the vaccine. There seems to be this very ebb and flow of what's happening. There are other countries coming forward saying they're going to stop doing certain vaccines and in certain demographics and cohort groups. Does not seem that that's moving the needle quite yet in the US. So we'll continue to watch that. One other interesting thing, Jeff, I thought you might find this interesting. Dentsply acquired Propel this week. So they're gonna, that's interesting because they also bought Bite, right? Isn't that correct? They bought Bite about 6 months ago, and then they just acquired Propel today or this week. So it's interesting that how they're moving into the clear aligner and orthodontic market. I would assume that those could be, a married play there to hit that vertical market, which they don't really have yet.
Yeah. So, I mean, and the thing about Dentsply, obviously a huge company, and they have a history of acquiring companies and not doing as much with the companies that they acquire as they could, like a lot of companies with huge potential. What I will say is, I think, and this is opinion,
editorial.
We do a ton with Propel and aligners to create new airways, not just for children, but for adults. So this is a potential huge acquirement for them. This is huge. I hope that they will put the resources into it, because Propel was a fairly small company and they never got to put the marketing in that I felt like they could have used.
Yep.
But I would love to see Dentsply really blow this market up, and having now scanning, aligner treatment, bite, they are in a really unique position at this point, and it's just what they do with it. So I really hope they do a lot. For those of you who don't know Propel, again, we have no sponsors on this show. Propel is a micro osteoperforation technique that basically it's
little holes, Chad, little holes.
Yeah, I was gonna say I'm gonna have to look that one up. That's a lot of letters.
Holes.
That's a lot of letters.
It's an osteoinductive process. In other words, we can grow bone where we didn't think we could grow bone before, and we can expand arches that we didn't think we could expand, and we could move teeth to where we didn't think we could move them before. So it's really a cool technology, and I'm glad that there's some money behind them. I hope that they put the resources into that.
I agree. When these mammoth companies come in and take over by these smaller players in the marketplace, it's always an interesting play, and many of them divest it right back out again because at some point, they've lost some of their ability to be nimble, right, and to be flexible and responsive and innovative, which most of these mammoth companies, by the time they get that large, it becomes much more difficult. So I think it will be something to watch. Honestly, Dentsply in general is always something to watch because they've been actively very busy spending money for the last little bit. So they have a play in mind, or some technology, or something's happening, I'm sure. So we'll just keep watching.
No, they're getting where the market is going, which is which is towards orthopedic dentistry, airway dentistry, and things of the sort. Like I said, I hope they put the resources that are needed.
Agreed.
Yeah. What else you got?
That's it.
Really?
Yeah.
Yeah. Chad, we got a dock her pay this week.
Yeah, I do have an update. They did find remains next to a notebook.
There you go.
That belonged to Brian Laundrie. So hopefully Gabby Petito's family will get some closure in that horrible incident.
Maybe it is him. Maybe. But
we don't know yet. We'll wait and see. I hope they had found him alive, but
personal opinion is this guy is crafty as a rooster, and I think
I was gonna say,
it'll be interesting.
He just bought himself some more time.
Yeah.
Possibly. Let's bring our guests on.
We did lose Colin Powell this week, former Secretary of State. I think a phenomenal military individual who served our country for a really long time. That I would be remiss if I didn't mention that.
Yes, you would. So
I would.
Rest in peace, Colin Powell.
All right, JB, why don't you bring our guest on?
You want to?
I do. I want to bring our guest on. I want to talk biomimetic dentistry.
All right. Chad's going to totally geek out. Just when we pick on Chad about being dumb, this is his wheelhouse. He's going to lose it. So I actually met Brandon for the first time tonight. He and I have chatted a little bit on Instagram, but I've been following his work for a bit, and I think he proposes some really interesting techniques for biomimetic dentistry. And I think we were chatting before the show, there's a huge gap for, I think, dentists, particularly if that wasn't a part of their dental education when they left. We didn't talk anything. I'm 14 years out. There was no mention in dental materials about biomimetics or bioactive materials. That really wasn't on the radar at that time. And in, a decade, things have changed pretty dramatically. And I think there are a lot of folks on our show, and there are a lot of dentists that have this big question mark about, How do I bring them onto my practice? What does that really look like? Are they as successful and effective as the materials that we've been using for a really long time? And so I just wanted to have an opportunity to have someone who I've come to really enjoy the content creation that he's doing on Instagram and putting his work out there, to talk a lot more about biomimetic dentistry and what that looks like in a private practice setting. So with that, we brought Dr. Walker on. He's coming to us from Seattle, Washington, and just wanted to open the conversation up and talk a little bit about, you know, you're on the younger side of dentistry, I think. And so what got you interested in this particular area of dental materials and really got you jazzed to sort of incorporate this into your daily private practice?
Yeah, sure. First off, thanks for having me in. I got the blinds down because Armageddon is happening in Seattle right now, so I'm staying away from the
Are
zombies.
you downtown?
I'm not downtown. I'm in Ballard, actually.
Okay.
So we're a little safe, but no one's safe. Anyway, I would probably answer that question by, taking myself back to kind of how I got into dentistry, because, I did 10 years in the Marine Corps. And so I have a lot of military dentistry in my mouth, a lot of root canals, a lot of crowns, what have you. And even in the short time, I got out in 2015. I've had multiple crowns replaced, multiple fillings replaced in that short amount of time. And so part of the reason why I went into dentistry in the first place, because I had clocked so many hours in the dental chair as a patient, and I felt like I had some empathy to offer, to patients, because I had been through pretty much everything but an implant to this point. So my approach to dental school, I'm a year out of dental school. I'm 36, so I was one of the older students, and I went through dentistry with a very different mindset, or I went through dental school with a very different mindset, is trying to do better dentistry now that I'm a dentist than what I had experienced in my own body. And even when I was in dental...
I'm sorry, I got to interrupt you 1 second. Did you say you were 1 year out of dental school when you got into this?
I graduated June of last year.
Man, that's awesome.
No, I think that's an important point, because you actually just really surprised me with, just in our little brief talk before you got on. I just didn't expect to hear that. So thank you for clarifying that. Sorry.
Sure, yeah.
Yeah.
So I went through dental school, and like you were saying earlier, they didn't teach us a very methodical way to do composite dentistry. In fact, the preps that we were drilling in dental school were GV Black preps. They were amalgam preps. And I remember sending an email to my professor saying, hey, like, for this practical this Friday, are we prepping amalgam preps or composite preps? And he wrote me back and he said, well, Brandon, we're prepping both. It's a hybrid. It's a hybrid because we're not using a 56 burr with sharp line angles anymore. We're using a pear-shaped burr with rounded line angles. And that didn't make any sense to me, especially because in my time in dental school, every other weekend probably I was doing CE. And so I had a lot of outside influence from the real world. I was probably all of my professors' worst nightmare because I asked all the hard questions everybody else didn't want to ask. So, that got me thinking. I was in the lab late hours. I set up a lab at home in my garage, and I was constantly trying different composites, different adhesives, different flowables, different matrix systems, different techniques, layering, injection molding, snow plow, what have you. And I was just a nerd. And so we have one of the best adhesive professors at the University of Washington, Dr. Ali Sauter, very, very well respected across the globe. I didn't really know who he was at the time because I was just in my little world in dental school. But he came to me one day and he goes, hey, can you show me what you're doing with your composites? Because I'm looking at every other students, and no one is getting their composites as polished as you are. This was like 7:30 at night, and I'm sitting in the lab with him, and he made me walk him through everything that I was doing. And the problem was that everybody got issued 27 burr blocks. Nobody knew what was in the burr blocks or how to use the burrs or what they were for. Every student was just pulling out whatever, trying to finish and polish stuff back to plastic. And it's a total nightmare. There's no protocol whatsoever. No one knows what they're doing, so every outcome is different. And so I showed him what I had learned in a CE course, and we went from there. But you know, I guess I would just say the trial and error of just different techniques that I was very curious about in school. And of course, at the UW, we have the Tucker Study Club, which I was very involved in, the Tucker Institute. So I'd go upstairs and hang out with the greats during lunchtime when they were all there working on their patients. Lots of exposure to really good mentorship and people of different disciplines. I just kind of took it all in. And in the year that I've been out, I've documented my work all the way through. I started in year one. I've taken photos of all of my work and posted it on Instagram. You can scroll down to the very bottom and see my really shaky crown prep from the beginning. And that's helped me, you know, sort of self-assess and even get feedback from the global community on things that I can do to improve in different perspectives and different disciplines and philosophies. So I've just kind of been this huge vacuum, and that led me to biomimetics, essentially, because in my mind, biomimetic dentistry is sort of like the Tucker Study Club of gold. I mean, it's kind of, at least we try to do every single procedure, or, you know, we try to do every single step the best possible. Rubber dam isolation, air particle abrasion, cleaning the tooth, using the gold standard adhesives, using the materials that have material properties that match that of the tooth, that match that of superficial dentin, enamel, even in indirects, using Emax because it very closely emulates enamel. Every step of the way is just very meticulous and you know, very planned and highly supported by a wealth of very good quality evidence. And that's just the type of person that I am. I mean, you know, joined the Marine Corps because I wanted to be tip of the spear. I wanted to be the best of the best, and you know, they kind of broke me down and built me back up to kind of at least think that I am, or at least keep trying to be the best of the best. And that's what it's all about. And I do it because of the empathy that I have for my patients. I'm more of I'm less of a drive a Ferrari and live in a mansion, make a lot of money by doing high volume dentistry, and I'm more of doing very good quality or the best quality dentistry that I can do, and building value for my patients so that, you know, they can, you know, get the best care possible, or the best care that I have to offer.
So as I'm reading into this, I'd like to make a comment, and I'd say that, you know, a lot of people say, oh, well, you know, you have an unfair advantage. And I think that it's the exact opposite for you. I think you have a very fair advantage because you got the crap beaten out of you for 10 years in the Marine Corps, and you served our country, and thank you very much for that. But you went into dentistry with a level of maturity that a lot of people don't. I, for one, I started dental school at 20 years old, man. I mean, I went to college for 3 years, got into dental school, went through dental school, and wanted to get out as quick as I can. I did take a lot of CE during my residency, which was available to me at Baylor, but that really wasn't available to me in dental school. And I was broke. I didn't have the money to do that. But man, kudos to you for going in with a completely different attitude than I would say probably 95% of the dentists out there. And anybody out there is welcome to correct me if I'm wrong, but I love the attitude that you went into and the attitude that you came out with. I've scrolled through your Instagram page. I didn't get to the crappy ones yet, but you know, I haven't seen a crappy one at all. So kudos to you. But JB, you wanted to talk about one of the techniques that he's doing, and I think that that's really important because we were talking briefly about it before the show. I'd love to hear more about this.
Yeah, so we were joking beforehand because when I was in dental school, the only thing we learned Rib-On was really good for was periodontal splinting. And then
I can't get that shit to work for the life of me.
Well, and then you try to do it in practice and you can't wear gloves, you can't touch it. It's got all these rules and regulations that are so different from everything else you use. And I know I just froze up and thought, I mean, at some point, can I just use an orthodontic wire? If it's going to come with all these regulations, I'll just do something that's a little easier, tactile, less tactile sensitive. So, but you're using it in a very unique way, which frankly was one of the first times I had seen someone using it as a liner type procedure for underneath their existing composites. And maybe I'm interpreting that incorrectly, so please correct me if I'm wrong. But let's walk through how you're using sort of these different layering techniques. And when you say biomimetic, I think it's important for us to really define what that means.
That's what I want to hear first. First, talk to your opinion of what biomimetic is, and then some of the techniques that you're performing to emulate that.
Correct. What Jeff said.
Yeah. So, I think the most important thing, foundationally is to dispel the rumors about adhesive dentistry. There's still a lot of people out there and many, many schools out there that distrust adhesion. Adhesive dentistry has been around for over 20 years and they've almost perfected it. I mean, I don't know if you can, but they've almost perfected it to the point where if you use adhesive systems, dentin bonding, so there's a lot of people using the universal adhesives out there. All the companies want to save you time with universal adhesives and bulk fill composites. And a lot of the claims that they make about those materials are true. You can cure 4 to 5 millimeters on these materials, but what you have to focus on is what actually happens when you do. You can make that composite hard, 5 millimeters deep, but what happens when you do? A lot of times it becomes a white amalgam. And so, the first step here is kind of trusting in adhesion. We don't often use posts. We don't, anything that the traditional dentist would use, post and core, stuff like that. We're using adhesive dentistry to bond very, very, very strongly to the tooth. And so biomimetic dentistry is essentially restoring the tooth back to the state the tooth was in, or as close as possible when that tooth was born. So for example, we're building the tooth back up from bottom to top. And what that means is it starts at that adhesive layer. This is all composite dentistry, what we're talking about. If we're doing indirects, we're talking about Emax or feldspathic porcelain. But essentially, you're starting at that adhesive layer because the hybrid layer is the most important layer of a composite restoration. And so we'll often use the double bottle dentin bonding systems, SE Bond, SE Bond 2, SE Protect, Optibond FL are the main 4. They're considered gold standard adhesives. They consistently test to the highest standards in labs across the world. And you can get bond strengths to dentin double that of a bond strength to enamel, and we're talking 50 to 60 megapascals. There's studies that have been done that show that the enamel is connected to the dentin when the tooth is born, a virgin tooth, at about 51 megapascals. SE Protect by Carrare can bond to about 62 megapascals on a flat surface. So when you see me or anybody else, Steve Schiffenhaus, Matt Najad doing these Emax overlay restorations where C factor is essentially as low as you can go, you're able to achieve a very, very strong bond to those materials. And so what we're trying to do with the adhesive is get that hybrid layer very secure to the dentin floor, because the dentin seal is the most important. There's this magical 5 minutes that you want to wait once you apply the adhesive and cure, because curing doesn't stop when the light turns off, especially to dentin. It continues happening. If you think of the dentin collagen fibrils down in the tooth, and then the adhesive, it has to go down, infiltrate in, comes down here, and once you cure it, it starts to cure like this and things lock into place. If you stack composite onto that adhesive too fast and cure it, the shrinkage stress from the composite in a bulk fill situation especially will go boom. So the adhesive equation, as we talk about, tells us that if the shrinkage stress of the composite or the bulk of the composite on top exceeds that of the bond strength to dentin at that point in time, you will get a gap. So when we hear about post-op sensitivity, for example, there's all these products. Eliminate post-op sensitivity. Post-op sensitivity isn't a problem in my practice because I take the time on that hybrid layer. I use the adhesive properly, and I don't exceed, the limit of the composite on top of it until the bond to the tooth is actually formed. I don't need Gluma. I don't need any kind of desensitizing agent. I don't need anything, any other products. I use the adhesive. I use.
Brandon, some of the glutaraldehydes will actually decrease bond strengths.
That's true. Yeah, it depends on the adhesive. Even Microprime G. A lot of people use Microprime.
But I think people think that that's a no-brainer. I could just throw glutaraldehyde on anything, and not realize that may affect bond strength.
It covers up the problem. It doesn't solve the problem.
Right.
It actually covers the problem. You still have the gap. What post-op sensitivity generally is a micro gap at the adhesive layer. So when the patient bites down and they say 2 days later they have sensitivity to biting, when they bite down, they're pressing the pulpal fluids back into the tooth, and that's the pain that they feel. There's a gap at the pulpal floor. Dr. Sauter actually showed this with an OCT scan of the tooth of the composite curing, a live view of it, and you can see the composite shrink away from the dentin floor and up towards the enamel. The reason for this is enamel bonds very fast because it's highly mineralized, so your composite will bond to it. And then when you get the shrinkage stress, it shrinks towards the enamel up top. So if you're doing 2 millimeter increments and you're connecting to dentin and enamel at the same time, your shrinkage is going to go away from the dentin where the bond is the weakest at that point of time and towards the enamel. That's where the gap forms. Whereas if you give that hybrid layer time to cure, do a little 0.5 millimeter bit of flowable over the top of it, cure that, and then don't exceed 1 millimeter of composite within 5 minutes, then you'll actually get a very secure bond to dentin without rib-on. Okay. Now, people in busy practices are like, this is totally impractical. You can never do that. 5 minutes, that's a long time. Well, we always joke and said, David Alleman said, a biomimetic dentist always works on more than one tooth at a time. So if you can work on one tooth where you apply the adhesive and cure that, then go to the next tooth and start scrubbing in your primer, then apply your adhesive and then your flowable layer. By the time you get back to that first tooth, you're already at 2 to 3 minutes, and you can start incrementally doing your dentin replacement without exceeding a millimeter within that 5 minute time. So it's all about how you strategize. And so after you do that, so you want to use a gold standard adhesive, and you want to use it properly with proper isolation, do a 0.5 millimeter layer of flowable just over the dentin. Don't connect anything to the enamel too soon, and then you just do increments of dentin replacement with composite. By the time you get up to the enamel replacement layer, you can pretty much do whatever you want because that bond to dentin is very, very secure. Now, let's just talk about rib-on in a case like, let's say the tooth has had a crown. Let's just say it's an upper bicuspid and you've had a snap-off failure. So what you're probably going to want to do is endo and then a post and a buildup. Well, at the gum level, you're running into like, you're not in superficial dentin. You're probably in deeper dentin, which is harder to bond to. There's the outlet there. You can restore that tooth without jamming a post down into it. When you use a post, especially if it's a metal post, you're directing all of those forces down into the root. Plenty of studies to show that. Even fiber posts aren't necessary. If you think about it, you're putting a fiber post into a canal space, and then you're using the post because you don't trust adhesion. The post is there to retain the core. But in this case, you might want to basically aerobraid that dentin, clean it off really nicely under rubber dam isolation, apply your primer, apply your bond, do a very thin layer of flowable to seal the tooth. And then you can do a very thin layer. You can do your rib-on right over the top of it. And the way you use this is you put composite, like a paste composite or packable, down onto the tooth. You place the square of rib-on down into it as close to the tooth as possible. Use a micro brush with a little bit of bond on it, and that'll wet the rib-on. And so once you wet the rib-on, it kind of spreads, and the rib-on will lay very flat across the tooth. Then you cure that. Now, what does the rib-on actually do? The rib-on is there to provide a secure bond to the dentin. So those cases where it's very deep dentin, the rib-on is nice because anything you place on top of that, if you have a failure, and it's all about controlling the failure point. If you have a failure, that failure is going to be a cohesive failure, not an adhesive failure. So the failure is going to be above the rib-on. Your hybrid layer is going to be secure. It's going to be safe. And so you can do your buildup on top of that rib-on. If you wanted to do a crown, you could just do an overlay and bond kind of an overlay crown on top if you wanted to. But if you wanted some retention and you wanted to do a typical crown buildup, you could do that. And when you do that, there's no way for the composite to shrink but down, so you're good. But that bond to the tooth, that hybrid layer is going to be bonded at 51 megapascals probably under rubber dam isolation, air particle abrasion, and the buildup on top will be secure to that. So
Brandon, you just made an important. I'm sorry, I didn't mean to interrupt you, but I think you just made a really important point that I want all of our viewers to hear. You talked about mode of failure,
right?
Which I think many dentists don't really appreciate, because I think every decision that we make in dentistry is about mode of failure. How will this fail if it fails? And if I can make it fail in a way that makes it more favorable down the road, that's better for the patient. That's better for us. We talked to that a little bit because I think that was overlooked a little bit, and it was such a brilliant comment.
Sure, yeah. That's the question that everybody asks, right? That's the question that patients want. For some reason, too, dentists get really butthurt when something fails. Like our restorations are supposed to last forever. Orthopedic surgeons don't even guarantee their hip replacements for over 5 years, right? No one else in the medical field has a problem telling you that you'll need your knee replacement replaced in 10 years. But, we're expected to make a crown last forever on a 25-year-old patient, right? So my discussion with patients, and I learned this from my mentor, Dr. John Kim, is the restoration is going to last as long as it lasts in the mouth. I can only control what happens here, during the treatment. I can use rubber dam isolation and all the best materials in the world, but I have no idea what you do when you leave here. If you're chewing on, metal pipes in your basement, or, drinking Monsters all day long, that's out of my control. And patients generally understand that. And so it brings things into perspective. But they really seem to understand then. That's why then I tell them that's why I use rubber dam isolation. That's why this and this and this and this and this. And it makes the appointments easier because it's all about managing expectations. But the idea is that, I just had my friend send me a picture today. He's down in Oregon. He's great. He's actually a Bean rep. And he sent me a picture and he said, "Hey, I just got my cleaning. The doctor came in and told me I needed a crown before he even sat down." He had just a little chip on his lingual cusp on one of his upper bicuspids, just a little enamel chip. But that's a cracked tooth. That's a cracked tooth. And so he was told he needed a crown. And so of course he sent us the photograph and he said, "Hey, do I need a crown?" And we said, "No, you don't, because a crown, you're missing 1% of your tooth. The crown, you have a crown done, you're going to be missing 76% of your coronal tooth structure." And that's too common, right? That shouldn't happen. That's a very aggressive jump with the adhesive dentistry and the materials that we have today, it's a very aggressive jump from a chip in the enamel to a full coverage crown. So, and I tell patients, like, if they presented with that, you know, they would, do I need a crown? They're programmed. Do I need a crown? No, you don't need a crown. I could do a crown. Crowns are fine. Crowns are great in certain circumstances, I think. If the tooth is just so destroyed that you have no other options, then a crown is great. But to go from a chip in the enamel to a crown, I think is more of a financial decision, personally. A lot of people do it because they're more comfortable with that. It's more predictable for them, or, you know, they just don't trust. That's just what they've been taught. That's what everybody's been programmed. So I tell people, no, you don't. You might need, you know, maybe we need to do full coverage something. In that case, we might do an onlay. We might do an overlay in that case, but never a full coverage, never to a full coverage crown, because the studies show that when you cut a tooth down to the gum line for a full coverage crown, you weaken the tooth. Everybody thinks a crown strengthens the tooth. You weaken the tooth. You've seen the non-carious cervical lesions, the notching down at the gum line. It's because the flexion of the tooth under function is causing that, typically. Heavy brushing as well, other factors, clenching, grinding. But that's where the tooth flexes. If you knock that out, we call it, in the biomimetic world, we call that the biorim. If you knock out the biorim 2 to 3 millimeters above the CEJ, you severely weaken the tooth. If you knock out the cingulum on an upper central incisor, you severely weaken the tooth. And that's why you get those crown snap-off failures. When we talk about failures, you're actually putting the tooth more at risk for failure when you prepare it for a full coverage crown. That's not to say that crowns don't last. Crowns last a long time, especially if you take care to make sure that the function is good at the end. And that's why with the Alleman 6-lesson approach, the last lesson, the 6th lesson, is occlusion. And so, but in terms of the biomimetic world, if we can make, and I tell my patients, even with Emax overlays, I say this will fail eventually. This could last 20 years. It could last the rest of your life. When it fails, it's most likely going to be a fracture of the Emax above the biobase or the buildup. And all we have to do is flick off the rest, re-prep the bottom, and replace the Emax. The tooth will remain intact. We're all about preserving the length of the tooth in the mouth. And you can't really do that after a full coverage crown. Next step is a root canal. And the next step after that is an implant.
Brandon, that was the longest answer other than I have given to a question, but you just said it right there. So honestly, it's about telling the patient, look, it will fail at some point, but here's how we're planning for it to fail. And
Right.
when it does, here's how we're going to handle it. Not that it's never going to fail. And I think that that's such a key element in dentistry. So I'm glad that you brought that point up. And I'm actually worse than you at taking a long time to get to a really good answer. But
Hey, there was a lot of pearls. There was a lot of pearls.
There were a lot of
no
pearls.
doubt.
What's happening?
Yeah,
So-
no doubt. But and no one gets it more than me. Trust me, because you know, I can talk forever. But that's such a great point that you just made. So thank you.
Sure.
What are your thoughts? I know you're a big fan of Emax, but in the biomimetic world, what are your thoughts on the hybrid ceramics? You know, like the Cerasmarts, the camouflages, the Vita and Emax and whatnot.
I don't have a lot of experience with them to say.
I'm shocked because everything that you're saying, it seems like it would be something, if you're doing a lot of onlays and overlays, it seems like it fits what you do perfectly. So there you go. That's your charge from me. And I'd be happy to discuss with you
Me
afterwards.
too, because I'm a big fan of a lot of these material for overlays and bite rehabilitation cases. Because of
what you're doing, it's just a strengthened composite that's millable, that's super easy to do, but placing it over the base that you've created and keeping that hybrid layer intact, I'm sitting here thinking of how I can incorporate that, because I do a ton of inlays and onlays in our practice out of the hybrid ceramics. I'm a huge believer in those. And I think you really need to look into those. If you don't have much experience with them, I think you might fall in love with something new.
Sure. Yeah. I mean, right now my experience, I just recently started doing, overlays, onlays, overlays, within the last 4 months, probably. And it's because I took Steve Schiffenhaus's course, and I'm good friends with Steve. He's a great guy. And I learned a lot from him. My challenge with the first associateships that I had was being as OCD as I am about dentistry and trying to please the owner of the practice, because at the end of the day, it's all about production. And it was tough. And a lot of people, I mean, crowns are crown. There's a lot of crown offices out there because it pays the bills. I mean, I've been told if it's an MOD, it's a crown. It like kind of breaks my soul a little bit to hear that. And then, so my solution to that was, fine. Sometimes actually it does make sense. So I said, fine, you know what? Well, I'll do crowns, but my crowns are going to be overlay crowns, and my crowns are going to be on the top third of the tooth, or the top 2/3 of the tooth. And so that's how I started doing overlays. And I found, my assistant was funny because she said, wow, on your deliveries, they gave an hour for delivery. So the owner, he did his crown deliveries, zirconia, traditional crown deliveries, cemented, and I did mine. And she goes, wow, this is crazy. You're putting rubber dam on, you're going through all of these steps. And we were even etching the Emax in the back lab and bonding it on. And I was still done in 55 minutes. And she was like, I would rather have it done this way. This seems like a better way with all of the, you're meticulous. And that's true. And the patients see that too. And so when people are, especially, and I was like this before when I was like, biomimetics, that's just impractical. There's no way. Until I started doing it and learning about it. And people still tell me this today. They're like, how am I going to do that? It's just a change in your mindset. It's a change in your mindset, because the greatest thing about sealing the dentin is that you don't even have to make a provisional. You just hold the tooth in place with some opal dam, mesial and distal, so that the tooth doesn't shift. And you don't even need to do a temporary. There's no sensitivity on the tooth because the dentin's sealed. The patient comes back in 2 weeks. You don't have to get them numb because they're not going to feel anything when you bond it there. So a lot of these things are very practical to do if you change your mindset.
What do you think is a good educational source for folks who want to start learning more about biomimetic dentistry and, kind of dipping their toe a bit in understanding that more? Besides yourself, which, yes, that could be, that's absolutely a resource. So we can talk about that as well. You can talk about who influenced you, and then also how you're educating other dentists.
Sure. I always say Instagram is a great tool. It sucks and it's awesome at the same time.
Yeah.
There's a lot of really, really, really great dentists on Instagram right now. The biomimetic movement on Instagram is growing, and we have more and more and more people who are documenting every step of their work and posting it. Not in a, hey, look at me, I'm so cool, I can do great dentistry, but the write-ups, the captions under there are educational, and it's free. You have to be careful with that because there are some knuckleheads out there, but in general, I mean, you can at least see what's possible, and you can generally message a lot of those people, and they love what they do. They're so passionate about it, they'll respond and they'll teach you everything they know. As far as formal courses, I took the Alleman's Biomimetic Mastership. It's about an eight-week course that spans across 12 months because there's mentorship calls that continue. And we even have like monthly meetings where they do a lecture, and so the learning continues. That's awesome if you want to really dive deep into the science and really get a firm understanding of it. I think we get issued 120 articles. And so we go through 120 articles on everything from adhesion to occlusion. I know Matt Najad has his, I think he calls it a mastership, and it's very flashy. So in between the two, it's a matter of personality. What forum do you want to, what platform do you want to get it in? And I know Matt has a great course too. Steve Schiffenhaus is incredible for the foundations. Practically, he covers a lot of the science and the procedures step by step, but he also shows you hands-on. So the hands-on overlay course, and I know he has a hands-on adhesion course as well down in Gilbert, but he also has an online platform. So if you want to just sit and learn the stuff behind a computer, you'll learn a lot through his platform. We teach a hands-on course here in Seattle. Dr. Kim and I, we started off just teaching injection overmolding for aesthetics, black triangle closures, diastema closures, composite veneers. And then we branched out into still teaching injection overmolding, but with a biomimetic core, a biomimetic base. So the doctors that come through our course get sort of this foundation, adhesion foundation, and then they understand that the injection overmolding portion of it is all on the outside, the enamel replacement. It's fast. Our aesthetics course is one day. We do a live patient demo. So Dr. Kim will actually do live patient treatment there. The doctors will watch. We only have 6 to 7 doctors that come. So it's very small and intimate. Sort of, there's 3 doctors. So we're able to really work with the clinicians. Next year, and we have a 2-day posterior course too. So for the posterior stuff, it's a full 2-day course. And actually Davey Alleman comes in and guest lectures and teaches for that portion. So next year, we're going to do a 2-day advanced anterior course and continue the posterior course. And then we're going to do a dual ortho aesthetic course. So post-ortho aesthetic treatments, we're teaming up with an orthodontist here that does a lot of digital stuff. So we're doing fun stuff here. We just keep it small. We're not a product course. Mm-hmm. We introduce lots of different products and let the doctors try different things out. We just want to get the information out there and teach people to do better dentistry.
Brandon, thank you so much for coming on. We are actually at the end of our time right now. If you would please forward any information you have about your courses to JB, we will make sure that we put them on our site. But thank you for your insights today. Thank you for your time. And thank you for your dedication to dentistry. Honestly, it's amazing to see that from someone. I had no idea that you were 1 year out. And I'm so proud that this is what our profession is now. Because, this is, this makes me excited for what's happening in dentistry. So thanks so much. I'm going to tip it off to JB. I'm going to let you close us out tonight. And
I have 4 words before we go to JB.
All right. No, I'm going to change this. I'm going to tip it off to Chad to close us out.
I'm not going to close us out, but I just
go ahead and close
us
out because we're over time now. But Brandon, thank you.
Brandon, I hope you've heard this, and I know you have. You're younger than me, so I can speak to you somewhat like a younger person, but I will tell you, you're probably a hell of a lot smarter than me, so I'll give you that credit. Charge what you're worth.
Yeah.
Make sure you never forget that. And I think that goes to everybody out there. Charge what you're worth because you've got a great service. So, JB, close us out.
Brandon, thanks so much for coming on and taking a chance on us to come and chat about what you're doing and giving us a really great insight into, a world of dentistry that probably many of our viewers just really aren't, frankly, very familiar with. So it's always good to get them kind of a toe in the water, if you will, of what else is going on in dentistry and how it's changing and evolving every day. So thank you for coming on. Thanks, everybody, for watching tonight. Are you guys lecturing anywhere this next week or so that we should be talking about? Anybody?
I'm recording an Aegis event on Friday.
Okay. All right.
I don't know. It airs on November the 10th.
I'm going to the Buffalo Niagara group.
Oh, yeah. You might
what
be
are
able
you
to
talking
use
about
it.
there?
Teamwork and airway.
Oh, good. All right.
Teamwork makes the dream work, baby.
We'll
Story.
find our dinks all over the map or on the interweb. But thanks for joining us.
On the interweb.
Have
Or
a
whatever
great
they
night,
call
everybody.
that crazy thing.
The thing that Al Gore invented. Have a good night, everybody.
Good night.
See ya.